The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to the Advancing Excellence in America's Nursing Homes Medications Goal webinar. We're thrilled to have you be a part of this webinar and actually a part of this exciting campaign that we are working on. We are going to start with a polling question just to find out who all is on the line. So, Adrian, if you'll bring up polling question number 1. Excuse me. My name is Carol Scott, and I am the Field Operations Manager for Advancing Excellence. I work with the various statewide organizations across the country. What am I? It says I must. Sorry, I don't know what I need to do to have the poll show up. So I am not going to worry about it. I apologize. I guess we won't. Do the poll because I don't know what I need to do.
Carol, the poll's up and people are voting.
Oh, they are. Okay. I guess I just can't see it. Sorry. We want to just kind of know who's on the call and on the webinar. If you have questions as the webinar is going along, please write them in the chat box on the right-hand side of your screen. And at the end of the webinar, we've left 15 or 20 minutes to address those questions. So please feel free to write those chat questions down. And the results are, and I guess someone else is going to have to say those because I can't see them.
Well, it's 2% family member, resident, advocate, ombudsman, 80% director of nursing, administrator, other management staff in nursing homes, 2% direct care worker, CNA, dietary worker, etc., 7% trade association, culture change org, corporate staff, and 10% other.
Super, thank you. Okay, and if you'll bring up the next polling question number 2, this asks the question whether or not your nursing home has entered its goals since November of 2012. Excuse me, we're just trying to get a sense of which homes have gone into the website and entered what their 2 goals that they're going to be working on. Advancing Excellence has a definition for a participating home that says that this will be a home that has chosen 2 goals, 1 clinical and 1 process goal, excuse me, and will enter that data for those 2 goals. So we just want to kind of see what, how many of you have already done this, and obviously there's a response there that, guys, we haven't done it, but we'll do it as soon as we get off this webinar. Excuse me. So if you'll close the poll up, we will, you can tell me what the results are.
70% yes, 24% no, and 6% no, but I will see that it's done today.
Perfect. Thank you, thank you, thank you. Those are great numbers. Okay, well, let's just get right into the program. Again, I want to thank you all for being a part of this. Our speakers today are, excuse me, Alice Bonner. Alice is a geriatric nurse practitioner, and she's provided primary care for residents in nursing homes for over 20 years. Currently, she's the director of the Division of Nursing Homes for the Center for Medicare and Medicaid, CMS, in Baltimore. Following Alice will be the co-chairs of the Advancing Excellence Work Group. Dr. Keith Guest is a practicing geriatrician. He's president of the South Carolina American Medical Directors Association. He's active in the Carolinas Centers for Medicare for Medical Care, both in North Carolina and South Carolina Lane. He is a board member of Advancing Excellence and was the original chair of the medication work group. Following Dr. Guest will be Nicole Brandt. Nicole is a pharmacist and associate professor, geriatric pharmacotherapy at the University of Maryland School of Pharmacy. She's director of clinical and education programs at the Peter LeMay Center Drug Therapy and Aging. And following Nicole will be Miranda Meadows. Miranda works at the analytics branch of the Colorado Foundation for Medical Care, Colorado QIO. She's a program manager for the Partnership to Improve Dementia Care in Nursing Homes. So let's just get right started. Alice?
Well, thank you very much, Carol, and good afternoon, everyone. And thank you so much for sharing some of your very valuable time with us. On behalf of all of us here at CMS, both in Baltimore and out in the regions, we're really very thankful for all of your participation in the National Partnership to Improve Dementia Care and Reduce Antipsychotic Use in Nursing Homes. As so many of you are aware, the National Partnership that started about a year ago is really focused on the 3 R's. And for us, the 3 R's mean rethink our approach to dementia care, reconnect with residents via person-centered care practices, and restoring good health and quality of life. And so many of you are working on these things. I'm just going to talk for about 10 minutes before turning it over to the other speakers, and I really wanted to use my time to emphasize some of the things that we have actually been hearing from many of you and many of your colleagues around the country as you do this work. You know, we've gotten great feedback, we've gotten great questions, and in talking with Dr. Brandt and Dr. Guest and the other folks on the phone, the other presenters, we thought it might be useful to just highlight some of the areas where you're working and some of the questions that have come up. So the first thing that I really want to say is that this national partnership and the work that you're doing is really about improving dementia care. And even though today the focus is going to be on medications, and a lot of the focus, of course, so far has been on antipsychotic medications in this initiative, we don't want to lose sight of the fact that what we're really trying to do together is to improve all of the dementia care practices, not only in nursing homes, but across other settings like assisted living as well. It's the comprehensive approach that we take to people with dementia that this initiative is really trying to improve. And it's true whether people are receiving an antipsychotic or other medication or not. So the campaign started by pulling together a lot of tools and resources and setting up the Advancing Excellence website. And Miranda Meadows, who's on the phone, and Michelle Lockman at CMS have just been absolutely tremendous leaders in getting those tools and resources out there to all of you. But now we're at a point where we have this opportunity to really move forward. So we've put tools and resources out there. We need to know back from you what's working, what's not working. Are you having issues in terms of finding the data and the reports that you're looking for to help you with your quality improvement? What kinds of things are you really interested in focusing on in your facility? So is it training of direct care staff? Is it training of leadership and other departments? Are you interested in, you know, focusing on how your teams are functioning, focusing more on physicians and prescribers, and how you know, medications are prescribed, and also how you're using data. So, you know, CMS and many of our partners and many of you through your work with Advancing Excellence and the QIOs, we're really trying to do a lot of outreach to specific nursing homes now to find out what else it is that you feel like you need in order to either get started or move ahead in this journey that you're on. So again, we appreciate hearing back from you on what else we can do as CMS to work together with Advancing Excellence, the QIOs, the associations, AHCA, Leading Age, AMDA, and ASCP, and many others in order to support your work. So in particular, I wanted to say in terms of the data, we get a lot of questions about data and reports. Some of this is confusing because there's a lot of different groups that are trying to make different reports available, and they don't always match up exactly. It might have to do with the date ranges being different. It might have to do with how a QIO gets data versus how CMS gets data, and how quickly the data is uploaded in some cases, etc. So my point about this is we know that you're starting to use data much more frequently and much more effectively, which is great. We think it's one of the reasons why we've seen significant success so far in the campaign, and you're going to hear a lot more about it today. I would just say if you have questions or if you're not sure or don't understand the differences in some of the reports, please feel free to contact us. We've got lots of folks on our data team who handle many of those kinds of questions, particularly as it relates to the quality measures that are posted on Nursing Home Compare. I wanted to say one thing about the publicly reported measures because, again, this is something that's come up quite often. Just to remind people that the quality measures on Nursing Home Compare are there for the purpose of public reporting, and it doesn't mean that CMS is suggesting that, if there are exclusions, for example, right now, we exclude people from the measure if they have schizophrenia, Tourette's, or Huntington's disease. And these are all pretty uncommon. Not more than a few people in each nursing home generally have those diagnoses. There are exceptions. But CMS is not suggesting that those people would always be on an antipsychotic, nor is CMS suggesting that other folks should be on one or should not be on one. These exclusions in the data are simply based on public health analysis and scientific literature where these are 3 diagnoses that very commonly we see clinical indications for antipsychotic medications, and that's why they're there in terms of the exclusions on Nursing Home Compare. However, I wanted to share with you that all of the quality measures, the antipsychotic quality measures, will be undergoing review by the National Quality Forum, and they could change. And the most important thing is that we should not extrapolate from the quality measures and draw any specific conclusions about residents or patients. Those decisions should always be individualized, and there's a difference between publicly reported measures and clinical care and medication choices that a team of clinicians will make. So you're going to hear more about that in the program, but again, I just encourage you, if you have questions about that, to please let us know. So I wanted to just mention a few more things, a few thoughts of places that you may be working in terms of looking at antipsychotics in your facility. Again, stressing that this is only one of the components of good dementia care, but things you might consider are how are people getting put on these medications to begin with? Are they coming from the hospital on the medications or from the home environment, from the community on these medications? If they're not coming to your facility on the medications, are they perhaps getting placed on the medications on weekends or evenings or off shifts when the regular staff that knows these residents really well perhaps is not there to intervene, perhaps families are not there to intervene, or perhaps they are there. But what kinds of patterns do you see in terms of people getting put on the medications in the first place? You can get a lot of information that can really help your team to sort of tease out and analyze that, those patterns. By looking at people who are on the medications in your facility and going through the list one by one, you can really identify individuals for whom your team may want to target a gradual dose reduction. And the other folks are going to talk more about GDRs later on. But once you've looked at the people in your facility who are already on the medications, you may want to expand and look at other folks in the facility who are at risk for being placed on the medications. And again, getting your team together, getting the interdisciplinary focus and the input from families and people who know these residents really well can help you identify those risks and help come up with alternatives that do not involve medications. So the other thing that's come up in many of your questions has been, well, what are the surveyors going to look for? How will they be evaluating whether dementia care is appropriate and sufficient and is meeting the requirements for participation, and so that the facility would be found in compliance? And we do have some new guidance for surveyors that's going to be coming out hopefully within the next few weeks. And surveyors have received some training on this, and we're really encouraging the process of care and the process of decision-making to be what surveyors are looking at. Not whether someone is or is not on the medication, but how was the process of care determined and documented so that it's clear, that there was a clinical indication, that the medications are being monitored, that other non-pharmacologic interventions were tried first, etc. So those are the kinds of things that surveyors will be looking at. And again, it's not whether or not people have a particular diagnosis or they're on the exclusion list or not. The question of hospice has come up. There are a number of residents in hospice who benefit from the use of antipsychotic medications. All of that will be looked at on an individual basis, and it's very important that providers, surveyors, prescribers, pharmacists, all of us are doing that. There's no blanket answers to the use or non-use of the medications, whether a gradual dose reduction is done, etc. All of this is based on individualized, person-centered approaches to care, which is so critical in dementia. So again, just to refer you to the website, and there's going to be a lot more talk about that later on. There are many specific tools that we think will be helpful. If there are things that seem to be missing, or other types of tools you'd like to see us work on, the folks in the National Partnership, which includes all of you and your associations and other organizations, would be happy to try to work on those things on your behalf as well. So again, many thanks from us here at CMS for all your hard work. We know this is incredibly hard. We're talking about building systems sometimes in facilities that have had not nearly as much in place so far for dementia care, and really enhancing what you're doing so much of at the bedside already. But again, thank you for all the hard work, and I look forward to listening to the rest of the webinar. So Carol, back to you.
Thank you, Alice. We appreciate CMS being a part of the Advancing Excellence webinars. At this time, I'm going to turn it over to Dr. Keith Guest. Keith? Well,
Carol, can you hear me?
Yes, I can. You're on.
Okay, cool. Well, thank you very much, and thank you, Alice. That was great. One of the things we've been doing at Advancing Excellence is coming up with several new measurements, and one of the newer of the 9 current measurements that we have now is a work group that has been working with medications. The title of the work group is Using Medications Appropriately. The first class of medications that the work group chose to work on were the anti-psychotic medications. We chose this because of the CMS initiative to improve dementia care, and because we thought that this was an area that was very relevant to all of the nursing homes across the country, and trying to improve the quality of the lives of their residents by appropriately using this class of medication is extremely important at this time. In the future, the Use Medications Appropriately work group will be focusing on other medications as the need appears. You may know that we have a big problem with antibiotic resistance in the United States, and in the future we may be using the same type of tool for medicines like antibiotics. And there'll be a track that you can follow for antipsychotics, or one that you can follow for antibiotics, or one that you could follow perhaps in the future for things like hypnotics and sedatives. But for right now, the first class of medications that we started on were the antipsychotics. We had a lot of good people on our work group. Dr. Bonner was on the work group. We had people from Health and Human Services. We had people from Advancing Excellence. We had people from the Colorado Foundation. Each of these, and we had people, former presidents of AMDA, the quality managers from ACA. We've had people who were specialized in public service announcements. So each of the people, if they're on the call today, I want to tell them thank you so much for your hard work. It was a difficult task to accomplish, but I think we put together some excellent tools and resources for everyone that will improve the lives of the people within your facilities. There we go. Next slide. And as I said, this one of the objectives of our work group was to ensure that the residents receive the medications that are needed and appropriate, and the initial focus is on antipsychotics in alignment with the Improving the Care of Persons with Dementia initiative. Development of tools and resources have been done, and that will help you to evaluate the use of antipsychotics within your own facility. We are interested in promoting a consistent message regarding the risks and benefits of antipsychotic medications. There continue to be articles that you will read about in the newspaper and in long-term care magazines that will highlight the risks of some of these medicines, but we don't want anyone to think that these medications are never appropriate. There are times when people have delirium or at the end of life when they have terminal delirium that these medications are useful and appropriate. We just want to make sure that you're using them in the correct manner and to improve the lives of the residents. We want to make sure that you're aware, and we have provided multiple links in the tool to non-pharmacologic interventions that can be used and that should be used, in fact, before you turn to an antipsychotic medication. These things are shown to be equally as effective as the medications themselves, and in many cases, they are more effective than the medication. There's some polling questions here, and I'd like to get my co-chair of the work group, Dr. Nikki Brandt, to help guide you through some of these polling questions. Nikki, are you around?
I'm on the line. Hopefully you all can hear me too. Good afternoon, and thank you, Dr. Guest, for that introduction. Sure. As mentioned, I've joined as co-chair. We thought, especially when you're talking about medications, it's great to have a pharmacist on the team too. So for many of you, you may know me or may not. I'm a practicing pharmacist in long-term care, as well as Dr. Guest, a board of director member for the American Society of Consultant Pharmacists. So I practice in long-term care, and I know how daunting psychopharmacological such as antipsychotics can be in terms of managing the risk and benefits. So what I've learned through my years as a practitioner is it truly takes a team. So I don't know if we can open up the polling question, Carol, but we'd like to poll all of you to see what you've been doing within your setting, within your facility, to give us some guidance, and we can talk about how these tools could potentially be employed by some of your team members. So I'll take a minute while you're doing that. The first one is talking about the creation of a psychopharmacological subcommittee. As you know, many of you have ongoing QA meetings, and on a quarterly basis at least, your pharmacist may be reporting to you. I have heard throughout the country at different meetings of different practitioners forming together QA sub-task force or committees. I'm not sure if any of you have done that. I know that there's differing involvement of psychiatry as well as psychologists, in your long-term care setting, so that was another selection. Training, I'm sure, but don't want to assume anything, that many of you have been doing ongoing training. So when we talk about some of the resources out there, we put some free resources that we feel are reputable that you can use in your training for your staff, in different levels of staff as well as family members and other stakeholders. Well, maybe like many out there, you're overwhelmed with so many other issues that you really haven't started focusing on this, and that's okay, because this is one of the things we have to continue to work on. And, well, maybe you're really, really lucky, so I thought this I would add. We don't have issues with behaviors or their management in our facility. And for those of you who use no antipsychotics, I'm not sure I'm aware of that. But if they're out there, then that's great, or don't have behaviors. But I think many of us day in and day out have some sort of behavioral issues within our facilities. So I don't know if we can show the results of the polling exercise. Okay, so we have a great breakdown here when we look at it. So it looks like at least 2/3 of you are creating some sort of subcommittee, as well as consulting experts such as psychiatrists and psychologists to the team. And at least almost 50% of you are doing some training. Well, education is so critical to a variety of team members, and we're going to talk about that within the tools that we've developed. And I love the honesty. Some of you have not had a chance, but I have a hard time believing that nobody has behaviors within their facility. So anyways, those were just kind of some exercises to get your brain juices thinking about how we can approach this and how we can address some of the issues out there. So what the work group has developed, and as Dr. Guest alluded to already, is there's lots of different resources and tools out there. We've tried to make it a little bit easier for you, so Miranda's going to go through the different tools. But we wanted to share with you that the tools that we put up there have been field tested. They can continue to be field tested, but we've used them within some of our own facilities. And I can tell you that, one of the important things with any tool is how it's utilized and how people are trained, and that takes ongoing training. But finding that opening communications, employing, as Dr. Bonner alluded to, the care process and incorporating high-risk medications such as antipsychotics in that care process, care planning, and really monitoring their use over time is pivotal, because as you'll see with some of the tools that we've put out there, identifying prescribers, looking at indication for medications, ensuring that gradual dose reductions are being done, monitoring for benefits, and again, depending on what the target behaviors are those actually target behaviors that would respond to an antipsychotic, and then monitoring when we take patients off of them for the emergence of those target behaviors or other negative outcomes. So I think monitoring, education are just some of the aspects that we've talked about. When we drill into, before we go to Miranda, before we drill into an issue, we provided some probing questions that you can use during your root cause analysis. And again, there's numerous educational resources out there, and we feel that it's not just education for facilities, but education for family members, for the residents themselves. And we try to use as much national websites and trainings that are free and accessible to the public. So we encourage the questions at the end of this program will be online for you to ask them, and I'm going to turn it over to Miranda now. Thank you.
All right. Hi, everybody. And Carol, did you want to make me the presenter? There we go. Okay. So, hi, everybody. My name is Miranda Meadow. I work with the Colorado Foundation for Medical Care, and I also work very closely with Alice Bonner and Michelle Lockman on the Partnership for Dementia Care nationally, and then I also participate locally in Colorado. So my role was to work with the medications work group to develop the Excel tracking tool. I'm going to spend most of the time focusing on that, but before I get to that, I just wanted to spend a few minutes kind of talking through what is available on the website, and then also how this aligns with QAPI efforts, because I'm sure that a lot of you on the line, particularly in the nursing home setting, are well aware of QAPI and its importance coming down the pike. So I wanted to spend some time just going over that. There we go. So the Advancing Excellence campaign it's national, it's voluntary, and it's aligned and becoming even more so with all of the efforts of CMS and the focus on reducing inappropriate use of antipsychotics. We are on the phone all the time to make sure that our efforts are aligned and that we are not duplicating work, but that we are working in concert with each other. To be a registered participant, you just go to the website and sign up, and we have a lot of those. We just passed the 9,000 mark for nursing homes not too long ago, which was quite a cause for celebration. And then you can also be an active participant, and that's what we're really focusing on now. Now that we've gotten these 9 goals up and we've gotten the tools out, we're really hoping that people will start to submit that data online as they use the tools, the data that's rolled up at the end of the tools, so that people can go ahead and start tracking over time the trends for their own facilities, and it will also allow us for the AE campaign to track nationally trends and see where success is being had. Over here, this is the Advancing Excellence Circle of Success. It is the representation of the QI process, and it also aligns, it's very similar conceptually to other models of QI process, such as Plan, Do, Study, Act, the PDSA cycle. And I'll show you how those align in a minute. So these are the 9 goals, and as you can see, they run the gamut of different things that they're focused on. The ones in gold are the organizational goals, and these are, and the ones in blue are the clinical goals. So medications is going to be a clinical goal. And when you sign up, you're now being asked to sign up for each type of goal to make sure that the QI efforts are focusing on multiple aspects of improving quality in the nursing home. So the data and quality improvement process is really important to improving. And the way that you get where you want to be is to know where you're starting. And that is where data comes in, and I'm going to talk about that a little bit more moving forward. But we really want to know where we are. We want to set goals, preferably specific numerical goals. So, you know, a 5% reduction, a 10% reduction, 15%. And then as you move forward, how are you seeing success, and where are you seeing success? What are the processes that you're seeing that are actually moving you towards your goal? So this description of quality assurance and process and performance improvement is taken directly from some of the materials developed by CMS for QAPI. And then it's just a helpful way to think about the difference between quality assurance and performance improvement. In the past, quality assurance tends to be reactive and usually based on a specific episode. The idea is to prevent a recurrence, but it's not taking that first step before a problem occurs. So it tends to be retrospective, and it has historically been associated with audits, and there's usually a punitive aspect to it. Performance improvement, on the other hand, seeks positive change and seeks a proactive approach. So trying to determine what could be a problem, or what can we fix now before we have a bad audit, before we have a problem with survey. Your performance improvement is always going to seek to have measurable outcomes, things that can actually be counted and that you can use for data to trend and to provide to your team, preferably at all levels of the team in your home, to understand what the trends are. If your levels of antipsychotic use are increasing, then that's a red flag, and it needs to at least be addressed and determined if that's appropriate. Conversely, if they're decreasing, why? What's been successful? Have you instituted a new team practice, or has someone come on board that is really a change agent and is leading the charge in reducing inappropriate use of these drugs? So the QAPI change package that has been produced by CMS this really aligns with strategy number 5, to be a continuous learning organization, to focus on reducing antipsychotics and how you can do that using non-pharmacological interventions, understanding the resident, so really focusing on person-centered care, consistent assignment, making sure the staff is stable for that resident. All of these things are going to be part of a continuous learning organization that's ultimately going to help you reach your goals of making sure that these medications aren't being used inappropriately. So 5B is a change concept specifically noted for CMS, and it's to track your progress. So you always want to measure indicators, and those are some of the indicators that we're going to talk about that are in the tool. You're going to set these stretch goals. So, ideally, pick a goal that is achievable but not easy. I think is the best way to think about QI. You don't want to set yourself up for failure, but on the other hand, you don't want to shoot too low if you really think you can get there. Make sure you keep everyone in the home involved at all levels of staff. I've talked with nursing homes who have everybody on board, including housekeeping and groundskeeping. Everyone who interacts with a resident should know that this is an important goal for the nursing home. And you want to openly and transparently share that performance data, good or bad, so that the whole team, everyone involved in this, can really focus on doing it together. And then the change concept is to test. So that's what this tool is going to do. You're going to be able to gain momentum. And ideally, you can take advantage of existing performance improvement templates, which is exactly what this AE tool provides. It's certainly not the only tool out there for tracking this, but a lot of work has been put into making this a tool that's easy to use, that is comprehensive enough without being burdensome, was the hope. And then this just summarizes kind of what I already said, that the AE tracking tools really do support QAPI. And this one in particular, you're going to be able to see every prescription at your facility that's written for an antipsychotic and understand which resident it's for, who's prescribing it, what the dose is, how it's been written, and whether a gradual dose reduction has been attempted. So some of the questions that I've gotten is, why would you use the medications tool when you have access to CASPR data? So I just wanted to address this really quickly. The main difference is CASPR data is valuable. There's no doubt that it is something that a nursing home needs to be aware of. But what it can't get at is those incremental process improvements in real time. Because of the data lag and because the measures are really yes-no measures in terms of reducing, since it's just a percentage of residents on antipsychotics, if you manage to dose reduce, if you manage to get a resident who has 2 antipsychotics to just 1, that's not going to be reflected in CASPR. And while the ultimate goal might be to get them all together off, depending on the resident, it's important to keep up the momentum, to understand what's working, and that's where the AE tool comes in, because it provides a comprehensive view of process improvement measures. All right, so onto the tool. The exploring the goal is part of the Plan, Do, Study, Act. It's really part of the plan part. And this is a screenshot of the Medications Explore goal. So it's just a description of what the goal is. It goes into a little more detail, and this is where any updates will be made. The Do part, that's the tool. And that is going to be your identify baseline. And for a moment, I'm going to navigate out of this so I can show you the tool itself. I have just gone ahead and entered some dummy data just to show everybody how it works. So you're going to download the tool from the website. Each Excel file is meant to be a month's worth of data. So every month that you track, you're going to want to go and download the tool from the website. You could save the file as a different month each month, but because it's an ongoing process of QI, sometimes we do make adjustments to the tools based on feedback that we get from users. So in order to have the most up-to-date tool, you really want to be downloading it from the website every month. So this is what the welcome page looks like. you're going to know what version the tool is and when it was last updated. And there's a link embedded directly to the AE website. And here you have hyperlinks to the rest of the sheets. You can also navigate along the bottom to get there. So this, the tool itself includes an introduction, instructions, glossary, Q's and A's, and then these are the three data entry. These are the three tabs where you're going to enter data. So I'm going to go through these really quickly because I want to spend most of the time just showing you how it works. There is just a quick introduction. There's a glossary of terms, and these are also embedded in the tool itself. So, but we wanted to make sure, the work group worked really hard to make sure that all the terms that could have any ambiguous meaning or could have different meanings in different settings was really clear, and so that everyone was on the same page about what they were referring to in this tool. And then Q's and A's, some of it is about the outcomes itself, and some of these focus on using the tool. And then there's also, you can always contact the Advancing Excellence Help Desk, and that email will be at the end of the presentation too. All right, so this is the first tab where you're going to enter data, residents on antipsychotic. So each resident, this is not, it's not meant to include all residents. It's only meant to include residents who have a current prescription for an antipsychotic. And so you're going to write in their name, whether they are short stay or long stay in your facility, and then whether they have more than one prescription. And this is important. If the medication is written as both PRN and a scheduled dose, that is considered more than one prescription for the purpose of this. And so if Betty Boop has a prescription for Haldol that's both PRN and scheduled, then it should be yes. And these are drop downs, these two. This is direct entry, and then you're going to select short stay versus long stay, and yes, no. Clinicians are, again, anyone who is prescribing in your facility should be here, who's prescribing antipsychotics. To make it easier on yourself, you can just go ahead and enter all the list of prescribing physicians in your facility and then just select the ones later who actually belong on the tracking log. So the first thing to make sure is that you are in the correct month and year for the data you're entering. And that'll be apparent when you click over here to when you're looking at your data for website entry, that should be apparent. So if that is wrong, just make sure before you go and enter your data on the Advancing Excellence website that you have adjusted it to reflect the proper month and year. So this is fed directly from the Residents on Antipsychotics page. You're going to have a drop down and you're just going to select the resident. I'm not going to go into this right now. Later, there are detailed instructions about how to de-identify your file for sharing purposes if you want, but that's what this is. This is a code so that you can make sure that you can share this data even though it contains personal health information. So when you enter this, it's going to automatically populate whether they're short stay or long stay based on what you said on the Resident on Antipsychotics page. And then you can select the physician that they saw. And you'll notice that some of these, that Mickey Mouse and Porky Pig occur more than once. And that's because this tool focuses at the prescription level. And so it's not just Mickey Mouse, yes, no. It's Mickey Mouse has a prescription for Haldol, and Mickey Mouse also has a prescription for lorazepam. And you want to make sure that you're capturing both of those because some of the process summary measures are based on dose reduction. So this is a drop-down of medication. I know it's a little bit small. You can always zoom in. It's just a function of, it's a limitation of Excel. And then you'll notice at the top here, a few of these are starred. And when I go back into the presentation, I'll explain this a little more fully. But there are 7 total fields that have starred red asterisks. And those are the required fields. Those are the ones that are needed to create the summary data. And so it's a relatively minimal data burden for those components that will actually get you the percentages. And then there are all these others. So you don't have to enter the medication, the prescribing physician, the dose frequency, or the route, and a couple others that I'll show you in a minute. We, of course, recommend it because the more thorough you can be in your quality improvement efforts, the more it will benefit you, and the more detail you'll be able to get out of it. But especially when you're getting used to using the tool and figuring out how long it will take you, we definitely recommend just starting with those 7 required fields. So another required is whether the medication is scheduled, PRN, or both, the diagnosis or clinical rationale. And you'll see that a couple of these are purple. And where they're purple, that's an indication that this might be a prescription that should be investigated further for appropriateness or necessity. And it doesn't mean that it's definitely wrong. It just means that, you know, if a medication is written PRN, there might be something that can be done to just, you know, there could be behavioral intervention or non-pharmacological interventions that could be used instead of having a medication for backup. Again, if you want to know what the target behavior is, whether it's been observed in the past 7 days, whether it's impacting the resident's functional status, those are all yes, no's. And then this non-pharmacological interventions present. These are a list that came from some work done at the VA of current non-pharmacological interventions. It's by no means exhaustive, and if the one you're using isn't on the list, just select other, and you can take notes on how the resident is responding, what the intervention is, then over here, whether a gradual dose reduction has been attempted, yes, no, and then the outcome. And the options for the outcome is that the dose was reduced, the medication was discontinued, there was no change in the medication, or it was medically contraindicated per physician. So, and some of these are going to be no's. There are obviously appropriate uses for these drugs occasionally, and so just because it shows up no and purple, that doesn't mean it's wrong. It's just the nature of this type of quality improvement work. So, whoops, let me go. So when you're identifying your baseline, after you've entered a month or 2 months worth of data, depending on how long you want to do for your baseline, you're going to start to see the information populate on this last tab, which is the data for website entry. And this information will help you answer some of the probing questions that Dr. Brandt mentioned earlier. If residents are on antipsychotics that are scheduled as needed or both, whether or not there are clear and acceptable clinical rationales for the use of medication, whether residents are on multiple antipsychotics, and that's really to get at the question of, are we managing side effects with more medication? Are gradual dose reductions regularly being attempted and documented? And are we able to reduce the number of medications or the dosages? So these are all directly from the probing questions that are available on the website as part of the package for this medications goal. So again, these are the required fields: resident name, state type, and whether they have more than one antipsychotic. And then resident name is just going to be the drop-down, how the medication is written, the rationale. So we tried to keep it really minimal for what you'd need to enter. These are the optional fields. So the tool can be really robust, and it can hold a lot of information that you guys can use for quality improvement purposes. But again, it just depends on the time committed and how you want to use the tool. So once you have entered some data and started to get a picture of how things look in your nursing home, you're going to study it, and you're going to examine your processes. And this is where those probing questions become even more valuable. And down here, for those of you who were sent the slides ahead of time, you can navigate to any part of the website. So this is one, so there's kind of groups of probing questions. So here is the overarching one, and then there's kind of these sub-questions for each of those to help the staff and whomever else is involved in this QI effort really dig in and figure out what's going on. You can download the whole list of probing questions in a PDF form. And then once you have a clear idea, you're going to want to act and figure out, okay, what can we do better? Let's try changing our process. Let's try having a different, more frequent meetings or really targeted meetings on one particular resident. And so what the work group put together is these resources that were referenced earlier. And they were board approved, and they focus on resident assessment, non-pharmacological approaches, dose reduction, direct care staff, monitoring, and consumer awareness. And all of these tools up here are free, and they can be used all together. You can pick and choose, but they have been vetted by many, many members of the work group and the board itself and they just seem to be the ones that will be most useful, especially in getting started with the QI process. And then in addition to those, there is the CMS Partnership to Improve Dementia Care in Nursing Homes website is also hosted on the Advancing Excellence website. And this is, as Alice Bonner mentioned earlier, there are just a ton of resources. More are being added every week. This is just a screenshot, but I really encourage anyone interested to go and look because there's just so much. And the thing that's going to, the next step is to create, some of our stakeholders requested physician packages that could be quickly accessed to provide to their physicians in the facility that would be most relevant to those providers. And then there's also leadership fact sheets that are aimed at the leadership in the facility itself, consumers, and then staff. And this is, oops, I'm going to go back out just to show you guys what it looks like when there's actually data in there. So as you enter, you'll be able to see these automatic calculations. So we have, of the long-stay residents, 50% have prescriptions written as PRN or both, short stay, none. And these will change as you enter data, and this will be a reflection of 1 month. And that's important because when you go in to enter the data when you go in to enter the data on the website, it's going to be important that you're looking at the right month. And just like you saw, just like I showed you before, to select the correct month and year, you want to do that again on the website. This is a screenshot, so it's set up exactly the same way, and then you'll submit. And that is it. And down here is the email for the Nursing Home Quality Campaign. If you have questions about the tool itself or suggestions, we're always taking suggestions to make it even more useful to nursing homes. So with that, I think we're going to open it up for questions.
Yes, thank you, Miranda. If anyone has any questions, just type them in the chat box on the right-hand side.
And I can read out these questions whenever you all are ready.
Okay, we're ready.
Can you please tell me again what 3 diagnoses are excluded for the use of AP meds?
This is Alice Bonner, and so in the nursing home compare long stay measure of the prevalence of antipsychotic use, the 3 exclusions are Huntington's disease, Tourette's syndrome, and schizophrenia. That does not mean those are exclusions for the use of the medications, as we said before. Those are exclusions in the publicly reported measure. That means if you have people in your facility who are on an antipsychotic and they have a diagnosis of schizophrenia, they will not be counted in the quality measure. They will be excluded from the quality measure. And the same thing with Huntington's and Tourette's. So that's what that means. So thank you for the question.
What month should we start? I.e., should we go back and enter several months or start with April, May? I assume that's referring to data entry.
Yeah, that's a really good question, and that is really up to the nursing home. It just depends on where you want to start. There are some that data tested it and went back a couple months so that they could establish a prior baseline. They particularly did this if they've already implemented some QI efforts or have tried to change processes and wanted to see if they could detect any sort of improvement based on the work that's already been done. But if you're just getting started on focusing on this work in your nursing home, then I would say you can start with April, May, and move forward from there.
What if the resident gets medications at different times, say 1 in the morning and 1 at night? Is that counted as 2 scripts or just 1?
If it's, we actually had this very question yesterday at the help desk. So if it's for the same medication and just given twice a day in different amounts, but they're both scheduled, so they're both going to happen every day, then that's just 1 prescription. But if there is a scheduled morning dose and a PRN evening dose, then that's going to count as 2 different prescriptions.
If a person you have on the log gets another prescription added later, do you have to just add their name at the end of the list, or is there a way to slide names down and copy and paste?
I'm not sure. Let me think about. I'm not sure I understand the question fully, but let me try and attempt. So the actually, I'll see if I can pull it up on my screen. The log itself, when you enter the resident name here, you're just going to enter it once. And so say in the middle of the month, Betty Boop gets a new prescription, you're just going to select that and enter the data appropriately over here. So I'm hoping that answers the question.
How often should the medication tracking tool be completed? If the resident is on a medication at the beginning of the month but then are taken off, do you remove them from that list?
That's a good question. I would say that is kind of up to the facility in terms of how they want to think about it. My recommendation for completing the tool is to do it at least weekly. That'll save some data burden, and it'll also keep details about particular interventions that are successful fresh in your head. In terms of taking a resident off mid-month, you know, again, because the measures that are calculated are not meant to mimic the CMS-QM measures. It's not going to. You're not going to have to worry about discrepancies between what you're seeing in your CASPER data or your nursing home compare data and this. So it really is kind of up to the home about how focused they want to be. But if they are dose reduced or the medication is discontinued during that month, you can go ahead and note that in that last column.
Can you remind me where I can get the physician packages?
The physician package is not quite ready. It should be up next week, and that will be, let me pull, so this is the homepage of the Advancing Excellence website, and down here there's a big blue button, CMS Partnership to Improve Dementia Care, and that's where all those tools are. They're all accordion style, and we will have one that says physician package that will include those.
Is there a place on the tracking form to enter total number of residents to get accurate percentages?
Total number, I'm guessing you mean total number like census data, and that's not currently part of the tool. So if you're wondering what percentage of your overall population is on an antipsychotic, that's not currently on the tool. This only includes residents who are, the denominator is going to be all residents on antipsychotics, not all residents in the nursing home.
Any suggestions with dealing with hospice staff who are using Haldol for fearful anxiety situations?
Miranda, it's Alice or whoever. Could you just reread that? I'm sorry.
It was a question about how, if you have any helpful recommendations for those using Haldol for fearful anxiety situations.
That's a great question. So we have been working more and more in many communities with our hospital partners, chief medical officers at hospitals, folks in the Society for Hospital Medicine, and the best way to really address that issue is with your local hospital providers. We have seen hospitals that have actually changed their standing orders and their hospital order sets for elderly residents with confusion and delirium to, in some cases, select much lower doses of drugs like Haldol, use other drugs, and the best of all, use non-pharmacologic interventions even in the hospital setting. Furthermore, Nicole? Yeah, we've seen people who are, at least discontinuing medications when they go to the nursing home from the hospital. So it's really important to have conversations, your medical director with the hospital chief medical officer or director of, the person who's on the P&T committee, the Pharmacy and Therapeutics Committee, or with the hospital pharmacist, consultant pharmacist to hospital pharmacist to have those discussions. It's a great question.
Nicole, this is Carol.
Yeah.
Would the same apply with a hospice?
Yeah, I think the question was with respect to hospice, and I think Dr. Guest is still on the line too. A lot of us deal with many hospice patients in long-term care facilities as well, and oftentimes the anxiety could be representing more of an end-stage delirium, where agents like haloperidol may be being used to help with that type of presentation. I think as Dr. Bonner is alluding to, coordinating with the hospice team and looking at what that agent's being used for. Again, you never want to cause distress in end-of-life care, and you want to be supportive, but at the same token, you don't want to cause someone to be over-sedated or, have no kind of responsiveness either. So I think there's a fine balance, and working with the hospice team, and as a consultant office, I'm consulting with the hospice team on what are we using these agents for, whether it's the lorazepam, whether it's the haloperidol, whether it's other agents that are potentially problematic in our patients. So I think it does take some scrutiny. I know there's a lot of discussion amongst hospice providers across the country in terms of this, and historically, and Alice can correct me if I'm wrong, but within F329, within the State Operations Manual, we talk about that particular being an exception in terms of care. So it doesn't come out that way in terms of the quality measures of reporting, but it is within F329. I don't know if Dr. Bonner, you want to say anything else to that?
Yes, first of all, I'm sorry I misheard the word hospice and thought you said hospital. But anyway, now we've answered both questions. In terms of hospice, yes, to your point, if someone has the appropriate clinical indications, which is, as you just said, very often involve severe anxiety and related symptoms at the end of life, then antipsychotics may be appropriately used. That needs to be documented. It needs to be documented, not just that, antipsychotics are always given as a standard, without individualizing, but that if this person has the appropriate symptoms and can be managed, best managed with antipsychotics, and they're clearly helpful for that person, then they absolutely may be used.
Yeah, and just to add one further thing, and some of our patients who are in hospice have severe issues with nausea and vomiting secondary to some of the treatments that they may be on, and things like haloperidol may give them relief for that too. So there's multiple things that these agents are used for besides end-stage delirium, so that might be clinically appropriate. But just like any medication, there needs to be an indication for use, and then there needs to be a monitoring of benefit as well as adverse consequences. So I don't know, Dr. Guest, if you want to add anything to that. We've had lots of discussions upon that as a work group, actually.
Sure. I hope you can hear me. I agree. There are times when these medications are extremely valuable at end-of-life care, and we don't want to discourage or prevent people from getting medications if they really need it. However, just like in any case, you have to make sure that there's a good indication. In general, anxiety is not an indicated use for an antipsychotic. However, terminal delirium, which as much as 80% of people who are dying will experience at some point, is an appropriate indication. And you just have to make sure that you use individualized, patient-centered care. Is that good?
Is there any other questions?
Sure. Are you tracking hypnotics, antidepressants, and anti-anxiety meds as well as antipsychotics?
So I don't know if that's a question for the Advancing Excellence tool, but I'll just say very quickly from CMS perspective, our data team is tracking those other classes of psychopharmacologicals and is looking for trends, because what we don't want to see is people simply switching without any rationale from an antipsychotic to another class of psychopharmacological. So it may be appropriate in some cases for somebody to be on an anti-anxiety agent or an antidepressant, but we are tracking and looking for that trend, and what we really want to see is that as much as possible people are managed whenever it is safe and appropriate without any of these medications.
And to build on what Dr. Bonner said, this is Dr. Brandt, is within the teams that are being built out there among some of these QA task force, it's broader than antipsychotics, because as alluded to again within F329, the state operations manual, they talk about psychopharmacologicals. And many of those agents, as I'm sure you've seen in the news, with agents like our Zolpidem or Ambien in terms of safeties and concerns. And so the target of this work group and this particular tool was to focus on antipsychotics, but it can be much bigger than that, and you can use the same care process when you're looking at indication, target behaviors, efficacy, toxicity. So the same type of framework should still be applied to these various high-risk medications, such as we talked about with psychopharms.
Is the information entered HIPAA compliant?
So I assume you mean HIPAA compliant in terms of whether or not, whether it's protected information. It is personal health information that is protected under HIPAA. But the data that would be submitted via the Advancing Excellence website is all aggregate data, and so that does not, there's no personal identifiers there. The tool itself is downloaded to your home's computer. So it's saved locally on a local network, so it's not a web-based application. And as I mentioned briefly, there is a way to de-identify the data, to de-identify both the residents and the clinicians. So if you did want to share this, say you are you belong to a corporate chain and you wanted to share it via email, you would need to de-identify that data, and there's detailed instructions about how to do that in the instructions available online next to the tool, and that's also a question that can be submitted through the help desk if anyone's having trouble doing that.
If you are a facility already working with a QIO on medication reduction project, will the data you collect be shared with Advancing Excellence, or do we need to keep and update two different data reports?
So I would guess that whoever's asking that is probably either working on adverse drug events or some other aspect of, or some other type of data collection through the Nursing Home Collaborative. That would not be shared directly with Advancing Excellence. But what I would encourage the asker to explore with their QIO is how they're working with Advancing Excellence, because frequently the Advancing Excellence staff, or sorry, not the Advancing Excellence staff, frequently the LANE, the Local Area Network of Excellence, works very closely with the QIO.
Some hospice agencies just order the antipsychotics as a standard hospice PRN order. Should we discuss a better process of not including it as a standard PRN order? Should the medication just be ordered when the SXs are exhibited? I think that's supposed to read symptoms.
Yeah, this is Dr. Guest. The use of antipsychotics as a routine medication in midlife care is not the current standard of care according to the American Academy of Hospice and Palliative Medicine. The medicine should be used on an as-needed basis according to person-centered care, and the medicine should only be used when they are appropriate, and it should not be part of any standing protocol to place patients on these medications. And you should discuss with the hospice agency within your facility about the appropriateness of using these meds.
I think this one's a little similar to what we got earlier. If the person has changes with their prescriptions in the month, like a dose reduction, do you enter them again in the same month?
Okay. No, you wouldn't want to enter them because you're really, in that instance, you're wanting to collect, you're wanting your data to reflect the fact that you successfully dose reduced. And so, you know, if it's, say that happens, sorry, I'm trying to get rid of this. Say that happens in May for, we'll say Betty Boop over here, and you had a dose reduction, then you're going to say dose reduced, and that's going to then feed into this data here, percent of residents for whom a GDR was attempted with at least one, or I'm sorry, who had a dose reduction, this one here. So then she's going to feed into that numerator.
And I think that our time is up. What we will do is we will continue to collect the questions that have been written into the chat area, and we will send those out to our panel members. We will then send out the responses to everyone who registered for this webinar.
And we actually got all webinar questions answered. That was the last.
Oh, perfect. Okay. Well, then let me just mention that you will be receiving a thank you email for being on this webinar, and part of that thank you email contains a link to a very quick survey that we are collecting that just asks you how helpful this was and if you have any suggestions. And so we very much appreciate when you get that thank you email to respond and give us your feedback. I want to thank all of the speakers today, Miranda, Dr. Guest, Dr. Bonner, Dr. Brandt, and Adrian in the Washington, D.C. Advancing Excellence Office. Thank you all, and please reach out to us if you have any questions or any issues about using the resources on the website. So Thank you, everyone, and have a good day.